I am going to be talking about the phase III Checkmate-915 study, which was an adjuvant trial of nivolumab combined with ipilimumab versus our current standard adjuvant treatment, nivolumab alone, in patients with resected stage 3B, C, D, and stage 4 melanoma. So in terms of background regarding this trial, we know that nivolumab alone, after melanoma is resected for stage 3B to D and stage 4 melanoma, improves the relapse-free survival significantly compared with ipilimumab, another checkpoint inhibitor, as an adjuvant therapy. We also know that ipilimumab improves the progression of the relapse-free survival and overall survival compared with placebo, which used to be our standard management paradigm only about 5 years ago. So for resected stage 3 or 4 melanoma, the standard was to resect and then we would watch. So ipilimumab first showed a relapse-free survival benefit, and then nivolumab in Checkmate 238. And so the next study is the Checkmate-915, based on data we see in the metastatic advanced melanoma setting, where we know that when we combine nivolumab and ipilimumab, we see a numerical improvement in both the progression-free survival and overall survival. So naturally, we wanted to see what this combination would do for resected stage 3 and 4 melanoma in the adjuvant setting. So in Checkmate-915, which I presented at AACR 2021, we did not see a benefit of the combination over nivolumab alone in resected melanoma. Now, the dosing of the combination in this trial, 915, was very different to what we use in the advanced melanoma setting from Checkmate 067. In this adjuvant trial, we used ipilimumab at a 1 milligram per kilogram dose every 6 weeks. Normally in the advanced melanoma setting, the dose of ipilimumab combined with nivolumab is 3 milligrams per kilogram every 3 weeks for 4 doses. So it was a bit of a challenge to see that we did not see an improvement in the relapse-free survival. In fact, the hazard ratio was 0.92. The confidence interval for that hazard ratio crossed 1. The p-value was 0.2, so there was no significant improvement. The landmark 2-year relapse-free survival for the combination nivolumab ipilimumab was 64.6% and 63.2% for nivolumab alone. No subgroups seemed to benefit. There really was no benefit at all for this combination over nivolumab alone. We looked at whether patients who stopped early because of higher rates of toxicity in the combination arm may have been the reason, because they did get less nivolumab overall. So the combination arm, because of the toxicity in the protocol, resulted in those patients getting less nivolumab overall. So we looked at whether that was a reason for this lack of improvement. But there was only about a 5% difference in the landmark relapse-free survival between those who stopped early, less than 6 months, and those who did not stop due to toxicity at less than 6 months. So that doesn't explain these negative results completely. It likely is due to the lower dosing of ipilimumab. We know that ipilimumab does have a dose response in the advanced setting. So the more ipilimumab you use, the higher the relapse-free, the progression-free survival and overall survival in advanced disease. So it's probably that, but we don't know. This is worth investigating. So what does this mean for our field? It means that nivolumab remains the standard, a standard anti-PD-1 therapy, along with pembrolizumab for resected stage 3 melanoma and nivolumab for resected stage 4 melanoma. This combination has not improved things further. We now need to go back to the drawing board and look at other ways that we can improve the relapse-free survival for this patient group. And perhaps it's a dosing issue with the ipilimumab. Thank you.